delighted to welcome our next seminar speaker, Dr. Sigfus Kristinsson, Assistant Professor of Communication Sciences and Disorders at the University of South Carolina. Dr. Kristinsson brings a unique blend of clinical and research expertise, having worked for several years as a speech-language pathologist in Iceland before earning his PhD in Communication Sciences and Disorders from the University of South Carolina in 2021. His research centers on the neurobiological underpinnings of language deficits and recovery in individuals with post-stroke aphasia, with a strong emphasis on translating research insights into clinical practice. Dr. Christensen's work bridges the gap between neuroscience and rehabilitation, making important contributions to both theoretical understanding and evidence-based care. We look forward to learning from his insights and experience at the intersection of clinical application and aphasia research. Thank you.
Thank you. Thank you for joining us.
Well, thank you so much for the lovely introduction, and thank you for inviting me to give this talk. So I'm going to be talking about personalized aphasia treatment today, and I just want to start by clarifying what I mean when I talk about personalized aphasia treatment. I view it as not as something that either is or isn't present in the clinical management of post-stroke aphasia, but rather as sort of a general framework that ideally should guide the clinical management of aphasia and treatment planning. So I'm going to talk about sort of what personalized aphasia treatment, what sort of challenges it faces in the clinic. I'm going to talk about some ongoing research and some future directions. All right, first for some housekeeping, I want to acknowledge that this work is funded by a P50 NIDCD grant awarded to Dr. Julius Fredriksson, PI of the Aphasia Lab at the University of South Carolina. And I'm gonna focus on two major areas in this talk. I'm gonna start off by discussing the foundation for personalized medicine in post-stroke aphasia and the current challenges, like I mentioned before, and then go into some recent and ongoing work that aims to inform personalized aphasia treatment being conducted in our lab currently. But I want to start off by giving you a bit of a background on how this topic became my bread and butter, if you will. I like to think of myself as a clinical neuroscientist. I am trained as a speech-language pathologist, and before pursuing my PhD, I worked with people with aphasia after stroke for several years. And I was a good student in grad school. I learned the methodologies, the aphasia treatment protocols, and I felt like I was in a good position to treat and help individuals with aphasia in the clinical setting. And my notion was, at this point, fairly naive in that I thought that if I administered treatment, then over time, I would see recovery. And that was sort of where my perspective at the time ended. But when I actually started working with individuals with aphasia, and the more participants or clients I worked with, I realized that this really isn't an adequate description of how aphasia treatment works, because even though some people responded well and quickly to treatment, other people did not, and there was really no guarantee that any treatment that worked for one individual would work for the next individual. And I found that really aphasia treatment, as you all know, doesn't have any one-size-fits-all solution, but rather that and that there were really no clinical instructions to navigate these issues of what sort of treatment to do with which client. So I decided to pursue my PhD, really to understand how the unique characteristics of each individual with aphasia can be used to guide treatment planning and optimize treatment outcomes. And I like to think of this topic as sort of fitting a puzzle piece into a template that fits perfectly or as neatly as possible, where the puzzle piece indicates or represents the individual with aphasia, and each puzzle piece has different and unique nooks and crannies that are really the goal then becomes trying to find or build a template that fits as well as possible. All right, aphasia treatment doesn't need any introduction to this audience, but I want to highlight a couple of points before moving forward. Behavioral speech-language treatment is an effective approach to improve language function in post-stroke aphasia, and there's a large literature that supports this notion or this claim. And I would argue that behavioral speech-language treatment is the mainstay or gold standard treatment to treat aphasia. However, if you are familiar with the literature behind this claim, you also know that even though aphasia treatment is effective and results in improved language function relative to no treatment, the effect tends to be quite subtle at the group level. So I borrowed this figure from Breitenstein et al., which conducted a randomized controlled trial comparing aphasia treatment to no treatment in a large group of individuals with aphasia. And as you see to the far left in the figure, there was a significant effect of aphasia treatment relative to no treatment, but this effect was very subtle. And this is arguably one of the largest and most cited studies for the claim that behavioral speech-language treatment is an effective approach in post-stroke aphasia. And we see very similar trends, patterns in the work that we do here in South Carolina, where at the group level, the effect of aphasia treatment generally is positive, but the degree of the effect or the extent of recovery we observe is quite subtle. Now, this plot is really my favorite plot and motivates my research agenda, if you will. This is data from the same plot shown in the previous slide, and this shows treatment response at the level of the individual for just over 100 individuals included in a recently completed clinical trial in our lab. And again, even though at the group level, we see a highly significant yet subtle mean improvement by about 5.9 items. I should note that this is reflecting change in naming accuracy and is ranked from the poorest to the strongest response. So even though we see this mean improvement, this effect really doesn't reflect what's going on at the level of any given individual, where we see large variability and really heterogeneous treatment responses. So aphasia treatment works, but who is responding? What are the factors that are associated with treatment response at the individual level? While there's a sizable literature that has addressed this question, and we know a lot. We know, for example, that factors such as lesion size and location are associated with treatment response, and the integrity of the residual language network sort of defines the potential for recovery at the neural level. We also know that factors such as general brain health and lifestyle factors, including exercise, are associated with treatment response. And specific to the data shown in the previous two slides, we found that aphasia severity was a strong predictor of treatment response, with moderately severe individuals showing better response than milder or severely affected individuals. And we also found, again, consistent with prior literature, that time post-onset and age were significant factors, with those who were further removed from their stroke showing better recovery, and those who were younger showing better recovery relative to older individuals. I would argue that these factors, and really much of the relevant literature on prognostic factors for aphasia treatment outcomes, really expresses the sort of general capacity to improve functional language with repeated training. So I want to take 3 example participants to demonstrate really what it means to perform prognostication in clinical settings to achieve this sort of personalization of aphasia treatment. These are 3 individuals from the same data shown in the previous slides. They are fairly similar in terms of their overall aphasia severity, assessed with the Western Aphasia Battery, which is a gold standard measure for aphasia severity. They are of similar age, ranging from 60 to 66 years old, but they differ in terms of their time post-stroke onset and lesion size, with participants A and B having a smaller lesion than participant C, and participant B being, having a shorter time passed from their stroke until they entered into treatment. Now, based on the prognostic factors I reviewed in the previous slide, we might expect beforehand that participants A and B would do relatively better than participant C in treatment. But this is really not what we see in reality. And I want to mention that these participants are obviously hand selected to show this point, but for participant A, who should have shown the greatest recovery based on these prognostic factors, we saw no recovery. But for participant C, with the largest lesion volume, we saw really quite good recovery, which again doesn't quite fit the profile. One potential reason for this is that participants respond very differently to different types of aphasia treatment as well. So any single treatment may work for one individual, but not for another individual. And this data comes from the same clinical trial where participants received 2 types of aphasia treatment, a phonological treatment and a semantic treatment. And here their individual responses are ranked based on response to phonological treatment in blue and overlaid with each individual's response to semantic treatment in red. So even though we found that in this data set there was a greater generalization of effects after semantic than phonological treatment, you'll see that some participants responded fairly well to both treatments, some participants responded to neither treatment, and a lot of participants responded selectively to one treatment but not the other treatment. And in fact, we found that there was no correlation between response to the 2 different treatments at the level of the individual. Moreover, we found that the factors that were associated with a degree of treated recovery differed based on the treatment focus. So individuals with more severe aphasia, larger lesion volume, and who had apraxia of speech present tended to do better with a phonological treatment, whereas individuals with milder aphasia, better preserved speech output, more fluent speech, and preserved phonological and semantic processing tended to do better with semantic treatment overall. So this really complicates what it means to use prognostic information to personalized aphasia treatment in the clinical setting. And this really is the core challenge that this line of research attempts to tackle. I like to describe it from 2 complementary views. One defined as the personal level factors associated with treatment response, and the other being the treatment factors that are really shape what sort of treatment is applied and how that treatment is tailored to each individual. Now, much of the literature to date has focused on sort of the face value factors at the person and treatment level, including factors associated with this general capacity for functional improvement, again, such as lesion size and age, and the efficacy of treatment at the group level. So whether treatment works relative to no treatment, or to a lesser degree, whether one treatment is better than another type of treatment. But the factors that are sort of under the hood, including factors associated with functional improvement in a specific treatment, such as phonological or semantic treatment, and the manipulation of treatment-specific parameters, such as dosage and treatment intensity, time in treatment, and those sort of factors. These have received much less research interest in this general field. So as a result, in actual clinical practice, the personalization of aphasia treatment really becomes sort of this matrix exercise where the clinician has to use their assessments of individual abilities and find the treatment that they think, believe, or have experienced in the past would work for that individual. And in that sense, personalized aphasia treatment involves integrating personal factors and treatment-related factors, as well as their interactions in treatment planning, in an effort to maximize potential treatment effect for each individual. And even though we know a lot, I would argue that much more work is needed to really realize this framework as a core component of aphasia treatment. What we do know is that we have a rigorous scientific evidence base demonstrating that aphasia treatment is effective, again, often compared to no treatment. And we do have numerous evidence-based treatment protocols, so a lot of different treatments, many of which work quite well. But we have a lot fewer studies that have compared two different types of treatment or have really looked at what sort of treatment works for which individual, assuming that it doesn't work for all individuals with aphasia. We also do have an extensive literature on prognostic factors for treated recovery, but as I alluded to before, I would argue that most of this literature, or much of this literature, I should say, focuses on these factors that are associated with the general capacity to improve functional language use given adequate training. So as a result, recent evidence suggests that clinicians are poorly equipped to use prognostic information to guide treatment planning, rather relying on their prior experience or clinical intuition, which in some cases may work out quite well, but the literature base that helps them navigate what factors are associated with response to what type of treatment, or in other words, what treatment to administer with which client is quite scarce. So in my research and in what I'm going to share with you in a little bit, I try to approach this broad issue by trying to address two specific questions. First, what neural predictors enable continuous recovery, and how are these reflected in behavioral traits? And how do these factors interact with treatment level factors, assuming again that any given aphasia treatment protocol is more likely to work for some individuals than other individuals. So with that, I'm going to shift gears a little bit and talk about some interesting and important work that we have been working on in our lab recently and work that is ongoing. Now, all of this work, even though the analyses are quite different, they share the overarching aim to inform the behavioral and neurobiological basis of treated recovery in post-stroke aphasia. I'm going to talk specifically about 4 studies in different stages of the publication pipeline. The first 2 studies focus more broadly on these general factors associated with the ability to improve functional language with training. And the second 2 studies focus more on treatment type specific effects. All of these analyses were conducted within the same data set, POLAR trial, which is a clinical trial that we completed some years ago by now, and is an abbreviation for predicting outcomes of language rehabilitation. So since all of these analyses were based on the same source data set, I'm going to give you a brief background about the POLAR study design before disseminating these specific research questions. All right, the POLAR study design has been published before, And you can navigate to the study design by following the QR code on the slide if you're interested in getting a more detailed overview. So this study, the main purpose was to identify predictors of different types of aphasia treatment. So participants were randomized to one of two treatment groups. They were randomized to receive either phonological treatment first, followed by semantic treatment, or semantic treatment first, followed by phonological treatment. Before any sort of treatment was administered, they underwent extensive baseline testing, including cognitive linguistic assessments, demographic and health history, and a detailed neuroimaging workup. And they then completed outcome assessments after each treatment phase and before the second treatment phase, as well as after both treatments had been concluded. Now, the purpose of this study was not to compare different types of treatment, but rather to use treatments that we know work from the prior literature and figure out what factors are associated with response to each. So for the semantic treatment, participants completed semantic feature analysis, verb network strengthening tasks, and a PACE-like barrier task. And for the phonological treatment, they participated in phonological components analysis, phonological production task, and phonological judgment task. And again, each of these was hand-selected because they had a specific degree of research pedigree to support that they were effective to improve language function in this population. And we assessed treatment effects with the Philadelphia naming test, which is a test, a confrontation naming test that has been shown to be a reliable proxy for overall aphasia severity and improvement in aphasia treatment. We recruited participants who were at least 12 months post-stroke after a left hemisphere stroke. All participants were between the ages of 21 and 80 years old and spoke English as a primary language and were able to undergo MRI imaging and able to provide written consent. And we excluded participants who were really limited in their verbal output or auditory comprehension, too limited to participate in the treatment tasks. Overall, we recruited 127 participants, 20 of which were stroke controls without aphasia, and 107 individuals were randomized to one of the two treatment arms. And retention was quite good, so most of these individuals were included in post-treatment assessments and follow-up assessments 1 and 6 months after treatment completion. Here you see just the participant variables and a lesion overlay map. This is in radiographic view, so what's shown on the right is the left hemisphere lesion. And this lesion overlap is fairly representative of chronic post-stroke aphasia, where we see lesion including the inferior frontal gyrus, deep white matter structure, temporal regions, and parietal regions in many participants. The mean age of the sample was 60.5 years. Participants were on average about 48 months removed from their stroke and had a mean severity of 60 points on the Western Aphasia Battery Aphasia Quotient, indicating mild or moderate aphasia. All right, that brings me to the first study. And for each of these studies, I'm going to give you a brief background and a fairly brief description of the methodology, but I'm happy to address any clarification questions at the end of the talk. But I'm going to highlight the results and how the results inform this framework that is personalized aphasia treatment. All right, so the first study focused on shared and unique lesion anatomy in post-stroke aphasia. And our aim here was to dissociate lesion anatomy associated with global impairment across all Western Aphasia Battery subtests and lesion anatomy uniquely associated with each subtest score. So we combined multimodal neuroimaging, including structural and functional imaging, with the Western aphasia battery subtest scores, which include spontaneous speech, naming, repetition, and auditory comprehension. And we constructed partial least squares regression models that we used then to extract features that were commonly reflected across the different neuroimaging modalities as being associated with impairment across all of the WAB subtests, and then used coefficient thresholding to distinguish features that across models were associated uniquely with any given subtest score on the WAB, but not the other three. So we constructed separate models based on each neuroimaging modality to begin with. And what I'm showing here is the prediction accuracy for the WAB subtests based on modality, but focused only on features that were associated with shared variance across the WAB subtests, but not features that were associated uniquely with any given subtest scores. And as an example, we used leave one out prediction to predict the extent of impairment on each subtest score based on a selected set of features, again, associated with that shared variance. And we found that two of the best performing models included the diffusion tensor imaging model and the cerebral blood flow model, which, focusing only on these shared anatomical features, gave significantly accurate predictions for each of the 4 subtests. Now, this was the first aim of the study. The second and more interesting aim, to me at least, was that we then regressed out the extent of impairment associated with these core lesion anatomy, and we extracted the features across modalities that were consistently associated with shared impairment across the WAB subtest scores. And this is what's shown in the slide here. This figure is going to look fairly familiar to anyone who works with neuroimaging data from post-stroke aphasia patients, with consistently implicated features including posterior temporal lobe regions, pre- and post-central gyri, and inferior frontal gyrus involvement. Now, after regressing out variance in the language scores associated with lesion to these factors, we then again used coefficient thresholding to identify features that were uniquely associated with each of the 4 subtests. And we found that across subtests, specifically that regions in the, deep white matter structures, basal ganglia, and several regions in the right hemisphere contributed to each subtest score. For example, for naming and repetition, we found extensive involvement of basal ganglia and parietal and frontal regions in the right hemisphere based on modality. And we found the greatest regional distribution for the auditory comprehension subtest. And by then, sort of as a proof of concept, we predicted language scores as a combination of lesion to these factors that were common across all of the subscores, and integrity of the areas that were specifically associated with any given subtest score. And we found that for each subtest, accounting for both the global network damage and integrity of the residual network, we were able to improve the prediction for each functional domain. And we took these results to conclude that aphasic language performance reflects simultaneously global network damage affecting all functional domains, at least those assessed here, and damage to regions observing specific functional domains, indicating that this this idea of personalizing aphasia treatment and navigating what type of treatment may work for whom may need to take into consideration the overall effect of lesion to the network, as well as integrity or lesion to regions outside of the canonical language network based on the functional domain. All right, the second study, which is quite different, focused on intra-individual variability and treated recovery. And this work is spearheaded by my colleague, Dr. Janina Wilmskotter, down at the Medical University of South Carolina. And our aim here was to examine what factors are associated with variance in naming performance, the extent to which variance in naming performance predicts treated recovery, and changes in naming variance after treatment. And this work is very much motivated by a handful of prior findings that suggest that the extent of intra-individual variability prior to treatment may offer a window into the potential for treated recovery after treatment. And this work leveraged the fact that before and after the treatment phases of the POLAR trial, we administered the Philadelphia naming test twice on 2 consecutive days for the purpose of, really the main purpose was to get a better, more reliable assessment of their naming performance. But it also enabled us to extract and compute different measures of naming variability prior to and after treatment. And for this purpose, we extracted 3 specific measures indicating naming variability. The first we call simply naming variability, and this measure reflects the absolute difference in accuracy on the first and second administration prior to and after treatment. So for example, if an individual correctly named 110 items before treatment, and no, not before treatment, on the first administration, sorry, and 115 on the second administration, their absolute naming variability would be 5 items. Then we quantified what we call practice effect, which takes the directionality into account by subtracting the score on the first administration from the score on the second administration. The rationale here is that for healthy individuals, we would expect to see a subtle but detectable practice effect with a higher score on the second administration relative to the first, simply by the individual having seen the actual items when they get to the second administration. So the practice effects takes this directionality into account. And then we quantified naming inconsistencies, which was quantified as the proportion or number of items named correctly on one of 2 of the administrations. So if an item was named correctly on the first administration and not the second administration, it would count towards naming inconsistencies, as would an item that was named correctly on the second administration, but not on the first administration. All right, then we examined first factors that were associated with the extent of naming variability, as defined as these 3 categories, reflecting intra-individual variance in performance. We assessed a subset of associations, including aphasia severity, aphasia type, age, education, and a handful more other factors. And we found that for naming variability and inconsistencies, that there was a significant association with overall severity, expressed as the Western Aphasia Battery Aphasia Quotient. And we found that both naming variability and inconsistencies were more pronounced in individuals with moderate relative to mild or severe aphasia. And correspondingly, we found similar results when we looked at aphasia type, where naming variability and inconsistencies were more predominantly observed in individuals with conduction aphasia and transcortical motor aphasia relative to anomic, Broca's, and Wernicke's aphasia. I will mention that we only had 2 individuals with transcortical motor aphasia, so I would caution against drawing too strong conclusions about that finding, but we had a sizable number of individuals with conduction aphasia. Now, in terms of naming inconsistencies, we also looked at item level associations, so whether words were named more inconsistently if they were less or more frequent, or based on their phonological neighborhood density or number of phonemes in the word. And we found really that naming inconsistencies were non-linearly associated with word frequency only, with more inconsistent naming observed on medium frequency words than very frequent or less frequent words. Now, in terms of treatment effect, we found a significant univariate relationship between the practice effect and naming inconsistencies and degree of treated recovery. These are the panels A and D to the far left here. In both cases, we found that greater practice effect, indicating better score on the second administration relative to the first administration of the naming test, and more naming inconsistencies, so more correct naming attempts for, more correct items named inconsistently across the two administrations was associated with better overall recovery. Now, to test the generalizability of these findings, we used fivefold cross-validation and leave-on-out prediction modeling. And after that more rigorous statistical approach, we found that the effect of practice effect was sustained and accounted for about 32% of the variance in improved language, whereas the effect of naming inconsistencies did not generalize in the cross-validation models. And in terms of change from pre to post-treatment, we found that there was an overall reduction in naming variability from pre to post-treatment, indicating that with treatment, participants became more consistent in their naming attempts, and that this whole space, irrespective of direction of the effect, that shrunk as a response to treatment. Now, we also found that there was a reduction in naming inconsistencies. So after treatment, individuals were more likely to name more items correctly on both administrations relative to incorrectly on one attempt and correctly on the other attempt. So naming became more consistent with treatment. And we took those findings to indicate that this intra-individual variability in language performance prior to treatment may indeed offer a window into an individual's potential for recovery. And in particular, both the direction of the effect, whether they do better on the second day relative to the first day, and the actual targets that they name inconsistently may offer sort of a potential pool to guide treatment planning, because these are the same items they tended to improve on as a function of treatment. All right, that brings me to the third study. These first two, again, focused more on the general capacity to improve in treatment, whereas the third study looks at treatment type-specific effects. This work is very much ongoing, so the results that I'm sharing are somewhat preliminary and might be updated prior to publication. But this work aims to examine the extent to which integrity of brain networks predominantly involved in phonological versus semantic processing predicts response to phonological and semantic treatment. The idea here is quite simple. If the breakdown or the extent of damage is greater in one network than the other, for example, if the damage primarily affects the phonological network, should treatment be focused on improving that functional domain, or should it really focus on the relatively intact network instead and use that as a strength to arrive at better treatment outcomes? So whether to treat the impaired network or leverage the fact that the other network is relatively more spared. So we defined the phonological and semantic networks with reference to the prior literature. The phonological network shown in blue was composed of the inferior frontal gyrus pars opercularis, the supramarginal gyrus, anterior insula, superior and posterior superior temporal gyri, and the semantic network was composed of the inferior frontal gyrus pars triangularis, the angular gyrus, the middle temporal gyrus, and the middle and superior temporal poles. And I want to notion or caution against drawing too strong conclusions here, because we do certainly find that lesion in one network is very strongly correlated with lesion in the other network. And we assessed functional activation in these networks as well, and found that functional activation in both networks was strongly associated with the degree of damage in both networks as well. So the independence of these networks and their effects is somewhat limited based on the correlational structure of the data. We found, we tested the main effects of damage in these networks and functional activation in these networks in a linear mixed effects model that was adjusted for the effects of overall lesion volume, aphasia severity, age, and time post-onset, since we had previously seen that these factors were associated with treated recovery in this sample. And we found that after accounting for these variables, damage to the phonological network was associated positively with treatment response after phonological treatment, and to a slightly lesser degree also with response to semantic treatment. We found no association between damage in the semantic network and response to either treatment. And these are significant main effects in the model, but no significant interaction with time point, indicating that this effect was significant at baseline and follow-up more so than being treatment specific. However, we also found that more activation, functional activity in the phonological network was negatively associated with treated recovery after the semantic treatment, indicating that more functional activity was maladaptive in this case for treatment response. And similarly, we found that activation in the semantic network prior to treatment was even more so associated with poorer recovery after semantic treatment only. I mentioned before that these results are preliminary, and there is an inverse interpretation of these findings, that individuals who had more activity prior to treatment were the same as those who had less potential to really reorganize or upregulate activity as a function of treatment. So further analysis of these data are certainly pending, but these results still warrant the conclusion that language reorganization following different aphasia treatments depends, at least to some degree, on dissociable functional networks as well as overall lesion size. All right, and finally, this last study that I'm going to talk about focuses on treatment-specific effects on acquisition and generalization of treated recovery. And this work really aimed to examine whether there was a difference in acquisition of treated items versus generalization to untreated items by treatment type, and to focus on behavioral variables associated with acquisition relative to generalization. And this work, which was recently published, was led by my colleague, Dina Blackett. And you can find this study published in JSLHR. This work really was a follow-up to the study I talked about at the beginning of the talk, where we had found that there was a significant difference in generalization after semantic and phonological treatment. And we found some specific predictors of generalization to each treatment type. So in this case, we really performed similar analyses, but compared acquisition as assessed with an in-house assessment we call the Treated 40, which is simply a naming assessment that includes 20 items that are treated in phonological treatment and 20 items that are treated in semantic treatment. So this is our measure of acquisition of trained items, whereas the PNT is our measure of generalization to untrained items. And again, just to reiterate, we found that semantic treatment for both treatment groups resulted in significantly greater generalization on the PNT than phonological treatment. So somewhat to our surprise, we found really the exact opposite pattern in terms of treatment acquisition. So when the treatment outcome was acquisition of treated items, we found a significantly and substantially larger effect of phonological treatment relative to semantic treatment. And we found similar associations to what we had found in the previous study. We found that for treatment type, irrespective of whether the outcome was generalization or acquisition, that there was a general pattern of better recovery in individuals with moderate to mild aphasia. And this generalized to the outcome type as well, where we saw that those individuals who showed greater acquisition after phonological treatment tended to present with moderate to mild aphasia severity as well. And we tested the extent to which the factors we had previously found to be associated with phonological or semantic treatment response in the generalization study. We tested the same factors and the extent to which these were associated with acquisition after phonological and semantic treatment. And again, the findings are almost the complete inverse of what we found for generalization. In this case, we found that better treatment acquisition was significantly associated with milder aphasia severity and better performance on non-verbal semantic cognition assessed with the pyramids and palm trees test, whereas acquisition after semantic treatment was significantly associated with the presence of apraxia of speech only. And these results really highlight that different treatment protocols may differentially affect acquisition of treatment targets and generalization of treatment effects, and really put into context and highlight that the different types of aphasia treatments may work on different levels of definition of treated recovery, whether, for example, acquisition or generalization, as well as for different individuals in both of these definitions. All right, so I'll be wrapping up. I know I've got a handful of minutes left, but I just want to conclude from these studies that personalized aphasia treatment in the clinical setting is really a large challenge at the moment and hardly possible given the current evidence that we have. But I would argue that we are certainly making progress. These studies, although very different from one another, really can be, well, I like to conclude that they highlight the difference between what it means to study or apply aphasia treatment versus what it means to treat individuals with aphasia. These findings suggest that all treatment protocols are not equally effective. That does not mean necessarily that one treatment is better than another treatment, but it may mean that one treatment may be better suited to improve treatment or treated recovery of the items that are targeted in that treatment, but another type of treatment might work better on generalizing those effects to untreated items. And one treatment may work better for one individual and another treatment for another individual. Now, in what I've shared here, this is only restricted to two types of aphasia treatment, but I assume we would find similar patterns of dissociations applying different types of aphasia treatments. Now, these studies also emphasize that neural and behavioral predictors inform treatment outcomes from distinct but complementary perspectives. Aphasia is caused by a stroke, and lesion damage is inevitably always going to be associated with the potential for recovery. But I would argue that it's important to understand how the neurological damage and integrity of the residual language network is expressed in different behavioral measures, because in clinical practice, behavioral assessments are what guide treatment planning, essentially. These findings also emphasize the importance of dissociating between these general and specific prognostic factors. Some factors may certainly be associated with the extent of recovery given any sort of treatment, but other factors may be associated specifically with response to one treatment or another treatment. And then finally, I think the next step towards the realization of this framework of personalized aphasia treatment would be to prospectively test specific models that give a prediction of who should respond better to any given treatment versus another treatment. Really to apply hypothesis testing to this knowledge that we have gained so far prospectively. So with that, I don't think I can in good conscience say that personalized aphasia treatment as defined here describes current clinical practice, but I do think that we are making steps in the right direction, ultimately to realize this noble framework that sometimes seems like an unrealistic goal in actuality. And with that, I just want to end by saying that I think this research topic, however challenging it may be, however many treatments need to be studied, or however many individual profiles need to be matched with different treatments, I think the meaningfulness of really taking these steps and being able to improve clinical outcomes and ultimately the lives of individuals with aphasia certainly far outweigh any challenges related to clinical research generally defined. So with that, I want to end by thanking all of my wonderful collaborators, many of which are shown here, others that were indicated in the previous slides, and yet others that, well, everyone I work with generally, and our wonderful research participants, obviously, as none of this work would be possible without them. So with that, I want to thank you so much for listening, and I'm happy to answer any questions.
Thank you very much, Sigfus. Do you have any questions in mind? People online, feel free to post your questions or unmute yourself and ask your questions. You wanna, yeah.
Sigfus, do you want to read the question at your side so that, or unmute?
Let me see.
Are people able to unmute?
I don't see any questions. Should I be seeing a question?
Someone raised
There's
their
a, so do you want to ask your question?
Hi, it was great study, sir. I wanted to ask you about how did you control this varied participants? It's very vast study in terms of understanding the factors contributing to the recovery. With respect to the semantic and phonological therapy, we all practice. But I wanted to ask you about, when the patients at home, they practice the social lifestyle, the cognitive reserve, linguistic reserve. I am completing my PhD, a little late in completing it. So I am looking at the cognitive reserve scale, the music and the lifestyle and the recovery pattern. And your study is really helpful. I have been reading your papers, they have been very helpful. So how do we control in terms of the contributing factors with respect to stroke, pre-stroke, the controlled and uncontrolled aspects, or all these patients are from a 20 to 80 years, you have mentioned, and a chronic stroke aphasia. So severe fluent, severe non-fluent with good comprehension versus with some arcuate fasciculus having a better connectivity with white matters. Did you try to have the ASL and also connectivity analysis, which could have been helpful, which the research is telling? So these are the two buzz questions I have for you. I would like to learn more on that.
All right, thank you so much. Well, please feel free to ask again if I'm missing any component of the question, but I think one of the question was, how do we control for factors really outside the treatment, right? Which may influence treated recovery. And the answer to that is really we control for what we realistically and logistically can, but there is always an element of the unknown that we cannot control. We know, or we would suspect, that participants with a stronger social network, for example, or those who are more physically active and socially active, that they might generally do better with treatment. But we don't control for these factors in terms of, saying people should stay at home and not do their routine activities, but rather we control for the factors we can. We ask them not to participate in other forms of formal treatment while participating in the treatment study, but to go about their normal routine beyond that. Does that answer the question, or did I?
Yeah.
miss
Yes,
Yeah,
anything?
I
yes,
think-
yes. Thank you so much. It was really helpful. One quick question about it, sir. Next to that, the imaging, what you have tried working on. So, could you please enlighten about the pre and post connectivity and the functional and structural imaging, what you have done, Dr. Kristins?
Yeah. We collect functional and structural images prior to treatment and after treatment, and then at the follow-up time points. I don't have off the top of my head the exact changes in the connectivity, functional or structural, but we have run some analyses in the past, but not any published findings. What we're doing now, like I mentioned, are those preliminary analyses where we're looking at the network, the phonological network versus the semantic network. What I showed here was just the frank lesion damage in these networks and functional activity only prior to treatment. But the other components of that study would be to look at changes in activity, task-based activity as a result of treatment, and changes in structural and functional connectivity. But that work is very much ongoing, so I hope you can watch that space in the near future.
Sigfus, I
so
think
much.
there's another question online. Can you read it, or do you want us to read it? It's from Matt Nelson.
I see it. That was a very nice presentation. I just have a small clarification question. How much time was there between the consecutive PNT test administrations before and after treatment? So the PNT was assessed on 2 consecutive days before and after treatment. So participants came in, and because we had a fairly extensive cognitive linguistic assessment that took quite a bit of time, they actually completed the PNT on the first day and the second day prior to any treatment. And then, since we had an extensive assessment after treatment as well, it was the same protocol. They completed the PNT on one day immediately after treatment, and then on the following day. So 2 consecutive days at both time points.
Can I ask you a question, Sigfus? And this might be, you might be thinking about this right now as part of all your different data, but I'm trying to put together your results from the naming inconsistencies and consistency. So something about how the system is trying to get to the answer. So that's why when they have a practice effect, they actually are better, more likely to improve because just the practice helps them get closer to the recovery. So that's one piece. And towards the end, you also showed data where patients who show good acquisition also have a better chance of showing generalization. The people who don't show generalization also don't show much acquisition. So that's another piece. And I'm trying to relate those two findings, which make perfect sense to us. I'm trying to relate those findings to the fact that you find greater activation before treatment is actually associated with worse recovery in that particular naming behavior. So is there something that looks a little bit like, I don't want to call it cognitive reserve because that's a slightly different term, but something about cognitive substrate, so priming cognitive resource that helps certain patients get better in treatment just because they have the system working for them. Are you thinking about it along those lines? Because you do have all these different data that are telling something there.
Yeah, I think that's a great question. And I think although we haven't really addressed that question specifically, I do have a feeling that that is the case to some extent. We do see, from different perspectives, we see that the participants who generally have better preserved functionality of different domains, whether it's language domains or even cognitive domains, they tend to do better across the board. So they tend to do better with acquisition, they tend to do better with generalization. And there's also an element to the same component in the variability data where, the same participants who are fairly moderate to mildly severe tend to show more variability. And, within that space of variability, they seem to be able to recover. I think the inconsistency data is the most interesting one in this respect, in that we do see a surprisingly large variability before treatment in a lot of participants, but the actual items that they are inconsistently naming, whether they're naming it correctly on one occasion and not correctly on the other occasion, this tends to sort of define the space where we see their recovery. So they improve on those items that they were able to retrieve on one administration and not the other. I don't think I have a concrete answer beyond that general feeling, since we haven't analyzed the cognitive reserve data or that question. But I do think that's a very valid point, and I do think that we can interpret our results in that sense as sort of an overall body of work.
Yeah, no, I don't mean to call it cognitive reserve, and I'm trying to come up with a better term for what we can call under the hood. Something is happening under the hood for these people that are somehow better able to respond to the treatment better, and some of it is in the brain, but there's something else going on. And I don't know what to call it, but there seems to be more than just 1+1, right? There's something else happening here.
No, I do agree. I think there is something more. It's challenging to quantify and describe, and cognitive reserve is maybe not the best term, but we do, for example, in some of the work that I didn't show here, we do see that this variability of those individuals who are more variable, there is a significant correlation with specific patterns of functional activity and functional connectivity as well, which is quite robust. And we sort of, the working hypothesis is that they do have some element that we can quantify in the neural data that potentially gives them better potential for recovery, some predisposition that puts them in a better position to improve in training. And that's fairly irrespective of the treatment type, but they show sort of a, what's it called? Like a precursor to showing language reorganization.
Yeah, good point. Yeah. I think you have another question on the chat. It might be easier if you read it.
Let me see. Thank you so much for the great insight. When you mentioned efficacy of personalizing aphasia treatments needs to be prospectively studied, I was just wondering, considering the possible variability across patients, for instance, in multilingual or culturally diverse populations, what core variables do you believe should be prioritized in prospective studies to test personalization? Lesion data, performance patterns, linguistic background. I think that's a great question. I think it's a very valid question. I think the actual extent to which we can prospectively test hypotheses about personalized aphasia treatment depends a little bit on the studies that or the prior findings that we do have, which are quite limited. I think focusing on factors that these studies and prior studies have found to be associated to some degree specifically with any given treatment, whether it's phonological, semantic, or otherwise, I think we would need to test those to see if those results generalize and whether these turn out to be reliable predictors of treatment-specific response. I do think there is some merit in the lesion data, the neuroimaging data as well, but I do think ultimately for this to be sort of clinically applicable or to actually improve clinical practice, again, I think we need to understand how these behavioral traits related to specific lesion factors or functional activation patterns that may be associated with response to any given treatment. I think we need to be able to interpret them behaviorally to some extent to inform clinical treatment generally. Beyond that, I think we simply have a lot of work to do, a lot of work ahead of us to come up with better hypotheses that predict response to any given treatment. But at this point, I think, again, I think the bottleneck is how limited the literature is on this topic to date. We have another question. Cognitive linguistic reorganized
I think
circuitry.
he was giving a suggestion of the title.
Yeah, I think so.
There's another.
Could I ask you if personalized efficacy therapy can be explored in line of cognitive motor linguistic social reserve? I'm exploring similar in my PhD, but heterogeneity in lesion and unavailability of biomarkers. My study in this phase is more exploring behavioral aspects of non-fluent aphasia. I seek some more guidance. Again, I think we are where we are because this is a topic that hasn't been extensively studied in relatively large groups of individuals with aphasia. We certainly do have a theoretical background that has some predictions about who should respond better to any given treatment sort of baked in. But in terms of actual data that have tested really any of these in the context of treatment-specific response, I think we are just very limited. I hope that gets at this question a little bit.
Well, you've definitely picked a topic. I mean, we invited you because we love the work you do, and your talk got a lot of people interested because I know that Snehil's in India, and I think the other person is in Malaysia. So they're all up at night waiting to hear your talk.
That's good to know. Thank you so much for having me.
Yeah, no, this is
Thank
great.
you.
We have we can always follow up with more questions, but we're way past 5 o'clock at this time. Any questions here? Are you? No, we should let him go.
Yes.
Perfect. Thank you so much for having me, and I look forward to speaking with you more in the future.
Yeah, we're excited about all this work. It's very exciting. It's hard work. We're so happy you're doing it. I think everybody's excited about your talk.
Thank you so much.
Thank you, Sigfus.
Bye.
Take care. Bye-bye.
Bye-bye.